Well, we'll let Julian work on some of the background pieces and be able to share some of the additional info with us. Paul, if you're ready, let's go ahead and get
Let's
started.
rock and roll. Yeah.
Okay. Yeah. So, good morning. This is our March 24th Eagles Zoom webinar that we are glad you're able to join us. That we'll do again in the same vein of Eagle Creek. Paul has added to the agenda and is ready to lead us onward throughout the next hour to an hour and a half. As a reminder, we do record this, and so we will post it after we process it and are able to put it on the US or useagles.org website that you'll have access to it afterwards, and feel free to share with your friends and colleagues as we go along. We're adding additional materials to the website for references and things that the folks talk about during the webinar. Again, it's not perfect, but it is a gathering point, and I think we're all feeling inundated with the infodemic and all the information is being shared. But nonetheless, it is valuable and is extremely helpful for us to be able to have this venue to be able to discuss the current issues, get updates from around the country and around the world, and learn what other folks are facing, how they've addressed and adapted to those challenges. So we appreciate our guests joining us as well today. But Paul, it's all yours. Let's go ahead and get started. Thanks.
Okay, got it. Hey, so I see a couple of people. I just so I can warn you, Meg. I make Meg Marine. I make. I lost my group of people who are on the chat here. So about that, Meg Marine. I may ask you to pipe in later, and a few other people on the line. And later, Sandy Schneider. I think you'll be prepared for some comments and so on as well. I'm just watching all the people that are popping in right now and making sure that I don't miss anybody, etc. And hey, and Craig, remind me, or if you guys can check and let me know if John gets on the phone, Kramer, okay? So, all right. So with that, so let me tell you a couple things. I wanted to recognize Craig, Craig Manifold, who is our national medical director for NAEMT, and Julian, who have put this thing on and have made it really a great success from all the feedback I'm hearing at different levels. So thank you guys for making this all happen and happen so flawlessly. It's gone very well. We're going to tighten it up a little bit more today, but the same token, I'm going to try to keep it as sort of the Eagles kind of flexible conversational piece and a little less didactic, but we'll try to do some of that here. So hopefully one of the things I have here is that I'm going to try to highlight some of the attendees that might be on. I don't know if some of these people are on the line. I think I see Scott Nichols is probably there, I think. If I see a 734 number, so probably is him. And
yeah, Paul, I'm on.
Good, thanks. And I'll tell everybody who that is. And some of our federal partners, I don't know if any of them are on yet, or John Kramer or any of the others. Pipe in if you are. I'm hoping to get some of the double Eagles in. That's the European Eagles on board. And I think Godo was going to try to get online with us. Are you there, Godo, by any chance? From Hamburg? Yeah, he's going to try to, are you there? Are you there, Godo? He was trying to juggle between his webinar right now with his fire chief, such as Glenn Asada as well. So the main thing is that we're going to cover a lot of topics today, and this is all stuff people have asked me to put on, and I don't want to rule out stuff that many of you might want to talk about, but we can do that or prepare for next time. But this is what I assimilated was probably the best, the most interest and highest level things that came up. And I'm going to try to therefore resurrect it in the original lightning rounds where you give a 20-second thing and not much more if you can, unless I've asked you to give us a kind of a didactic. We'll try to hold you to a few minutes under those things times as well. So consider this kind of a virtual Eagle Creek meeting. In fact, I'll probably call it Virtual Creek from now on as we do this. And then I'm hoping to let you know that I've established some communications with the others in Europe and Asia and Australia. It's unfortunately the middle of the night right now for them. And I may hold some other meetings in which we can do it maybe in the evening where we can pick up Pacific Rim partners in Australia. I've stayed in touch with them and things are going okay, sort of similar to the United States. It's sometimes regional, et cetera. And there seems to be heterogeneity and similarities within Europe so far in the States. And I have some people online. Jean-Louis, are you here by any chance, in case I have you pipe in later? I don't know if he's there. But Jean-Louis Vincent might be joining us later on, who's like really the leading guy in critical care medicine. Actually, he's the editor of Critical Care. And he's based out of Brussels, runs a major meeting every year that just totally outshines what we do. It's about 6,000 of us that gather annually in Brussels under his direction. So he's a terrific person I emulate. He makes me, in terms of publications, look like a slug. In fact, slug bake, I think. So we'll see if he pipes in, if he can get in with us later on. Let's see now. So this first graphic I just wanted to show you is probably kind of old, but it sort of is an interesting thing about places that have clamped down very tightly in parts of the world in terms of keeping everybody in shelter in place, have done reasonably well so far, such as Singapore and Hong Kong, etc. Whereas the other places didn't. And like in Europe, for example, there was less sheltering in place. They did not move early enough, is what I'm hearing from Jean-Louis, for example, today. And they did pretty well in Brussels, and they're doing less well, obviously, in Spain and Italy, as you've heard. And other places are sort of in the middle and sort of feeling a little bit like us, such as in the UK, but as we saw in New York City, etc. By the way, up above, I have on this agenda, I have a welcome back, my friends, to the show that never ends that you hear me put out. This happened to be right at the entrance to the Hard Rock Casino, where we're going to have the Eagle meeting this year. So that's kind of interesting. Can you go to the next page?
Hey, Paul, I'm sorry. It's Glenn Asade. I just, my other meeting got shortened. I'm here.
Yeah, okay. Will you be able to be on for a little while, or should I put you in right now? I mean, that might be the way to do it.
I'm good for a little while.
Okay, good. All right, so let's see. I wanted to see the next page. Well, I got my own itinerary here, so I'll just look at it, what we're going to do next. So what I wanted to do is we're going to cover one of the things that's come up. People want to get their handles around the clinical picture of COVID, and I thought that might not be a bad idea to do that because it really is very chimeric, and so you may have people who present in different ways and in different times, et cetera. And it depends on when you see them. If they're really sick, you may be seeing them present with the respiratory complaints. So I just wanted to sort of give us a better working idea about what that's all about. And then later we'll talk about some of the issues about when the testing is positive, when it's a false negative, when it's when you might start seeing it to be positive, when it's no longer, and some of the nuances that John Jew will try to talk to us about. And then I'm hoping to have Sandy Schneider on board. She looks like she's on the call to talk about ACEP because they've been asked to help take a point, sort of a lead role in over in with ACEP with the feds, and that'd be great to make sure we're all in sync on that. I wanted her to give you kind of just a quick report and let her know to put her on our radar screen. And then we're going to talk about some of the PP advantages, and Brett Myers, if he's here, may give us a report about what they're finding out. I'm hoping to keep that fairly short because we want to talk about distribution versus availability issues. There may be plenty of these things, we just can't get them out there. And then we'll talk about some other alternative approaches to how we're going to handle the PPE shortages if and when they come, if they're not already there. And then facing COVID, we'll talk a little bit about, if we can, talk about the dispatch areas. And then, and so some of the non-response, and we have a survey that the Eagles done, and hopefully if Jim Augustine is there, he can give us a report on those. So that roughly gives you some of the things we're going to talk about. I'll drill down on these later. I'm going to reserve the right to shift things around to make sure that people who are on the line that may have to get off and don't have the time are heard and so on, and or it may be just that we'll talk up, okay? So, for example, Sandy Schneider, I think, needs to leave at 11, so I'm going to try to get her on, earlier than later. But let's first, since Glenn could be called out any minute now because he has to, he has to do whatever he can. And so let's go ahead and get a report about what's happening in New York, because it sounds like you're the most overrun place so far in the United States, right, Glenn? Glenn, so.
Hey, good morning, everybody. Yeah, it's, everyone's going through this. I definitely understand. But, Washington State, California, New York, we have been identified as.
Okay. Hey, Glenn, hang on for 1 second. So for some of the people that are on the line, because they're our guests, if you didn't know, this meeting is run by the jurisdictional medical directors for the metropolitan cities, such as New York, Los Angeles, et cetera, in the United States, our counterparts in Europe and various places in Australia, et cetera. And so these are the people who are in charge of 911 systems in terms of medically, setting up the protocols and the responses and the dispatch, and even transport dispositions and so on. And secondly, or if you're in Europe, it's the 112 systems or whatever it may be, or 999 in UK. So, so our New York medical director, the chief medical officer for the city of New York, is Glenn Asada. And Glenn, go ahead, take it away and tell us what's transpired in your end of the woods.
Yeah, good morning, everybody. As I mentioned, the 3 states that have been identified as having the most cases: Washington State, California, New York State. Lucky us. We have been just really overwhelmed. Our hospitals are having problems, particularly with running out of ICU beds and PPE, to a point where, the CDC recommendations have gone from, in a known COVID patient, going away from an N95 to a surgical mask, and even reusing some of these masks. And I know that the nurses unions out here have said that's absolutely ridiculous because, you heard Fauci and everybody saying these masks, the surgical masks that everyone's wearing is worthless. And now they're saying, oh no, go ahead and use it and then reuse them. We've specified in our protocols that any aerosolized procedures, you must have the N95 eye protection as well as a gown and gloves. But based on the DOH recommendation now, if that procedure is not being done, we are ready to pull the trigger on a surgical mask and eye protection with gloves and gowns only, even in a known COVID patient where we're not going to aerosolize anymore, because just as the rest of the city and probably the country, we're having problems with obtaining the PPE. We have a lot of union issues as well, so we're looking at this. We implemented the fever, cough suffix to all of our call types. We usually run 4,200 calls a day to begin with. Now with the additional worried well and such, we have about 5,200, about 1,000 more calls a day. And that's not just the fever cough type, and we've had to change that from location. And I think Corey mentioned as a joke, travel history. Have you been outside your house? And that's really what it's become because of this community spread, community acquired. So we've had also positive members with the department on the fire side and the EMS side. Most of them have not been from patients, but actually from family members who tested positive and then infected our members. We've changed our quarantine and monitoring rules based on the Department of Health that was advised. So we've changed that to a point where, if you're positive, then obviously you're going to be on the quarantine. But if you've been exposed, even with breach of PPE, it's really monitoring with temperature and any symptoms. But you would actually come to work. When we identify a member as positive at a station, either an EMS or a firehouse, then we have an outside vendor that comes in and does a deep clean, similar to what the schools do. It's not done by the department, it's done by a vendor that the city has contracted with. Schools, like a lot of places, we have 1.1 million kids. They've all gone online starting this week to try to maximize the social distancing. The governor put out an order that says essentially stay home. Non-essential personnel, 100% of non-essential personnel are supposed to not go to work. Traffic has been fantastic here coming to work, but I'll take the traffic back to get rid of this nonsense. So hospitals are getting overwhelmed. They've requested some diversions, and we still allow diversions as a courtesy. Once we get to our 3rd diversion request, we open everybody back up because the system can't handle it. We're monitoring the diversions. The ICU beds are critical at this point. Equipment has been critical at this point. The social distancing, the governor was not happy. Over the weekend, he said that he had people going to Central Park and Prospect Park in Brooklyn, 2 of our largest public parks, and they said there are a lot of people out because the weather was good, and they're like picnicking. And he says that's not the purpose of it. So he's having NYPD in New York go out to start to disband people. We've actually had fire resources have been tasked with going to some of the restaurants, the bars and such that are supposed to be closed as of now, except for food that can be ordered to takeout. And they're also checking on sites, and we found still some people doing weddings, bar mitzvahs, groups of 200 or more. And so we've had to disband that. And, our numbers in New York State, as of this morning, we had about 16,900 cases, of which 153 deaths. In New York City, of those 16,900 cases, we have about 13,100 cases with 125 deaths. So in New York City, the 5 boroughs, we have 125 out of the 153 deaths. But overall, with the numbers, we have just under a 1% death rate. And with the thought that everybody wants to be tested more, if truly people were tested and 80% are really just kind of gotten over it without the death, I think the death rate, if you really looked at the numbers and tested more people, would probably be a little bit lower. Probably closer to South Korea, which they were a little bit better able to test. Problem for us also is testing, not available.
Yes.
So people have told me to say, hey, I went to the emergency department, they just sent me home. I want to be tested. That's not being allowed now. There's just no tests. So it's just chaos like probably everybody else.
Yeah, and that's the thing that's striking, that they're no longer doing the public health follow-ups on people and contacts, and that's all being eliminated at this point in time, correct? So
that's correct. They've done the medical detectives that they, proudly announced early, just not happening. They're just not even bothering with who did you see, who did you not. They're just assuming that everybody is positive. We've also limited the runs that our fire companies, our CFR, Certified First Responders, respond to. They usually respond to about 500 to 600 medical calls per day, but now we've tried to eliminate them being exposed, so they only go to cardiac arrest really now, the critical ones, and their response now has gone down to maybe 250, so about half of the calls they used to respond to.
Okay, so you're probably giving us a view of what many of us may still encounter. And so I'm sorry that you're going through all this, but it's classic. It's New York City, So, all right. Anybody have any quick questions for Glenn before we go on to the next speaker?
Hey, Glenn, it's Manifold. Thanks for joining us out of your crazy day. Any EMS protocols or processes that you've changed other than maybe the obvious of aerosolized procedures? Anything else that you guys have implemented that you think would be of value to our group?
Yeah, it's interesting because we were getting calls saying, I don't want an ambulance, I just want information about coronavirus. So we actually flipped those calls now to 311, our informational line that has a recorded informational line. And so we flipped those, and that goes down as a not ambulance, not sent call. Also, we've been working with ET3 for telehealth and such. So we were looking at that, and actually we're in partnership and speaking to the networks that might allow us to flip some calls of low acuity to these telehealth lines. So really the ET3 section. We've been meeting with them almost every third day or such to see what's going to be possible. Initially, they're very open to, yes, we can do this. We can take, a couple of hundred calls each per day. And now it's like, well, maybe we can't take as many as we thought because they're getting overwhelmed as well with their telehealth and their health lines. But we want to try to do a no ambulance sent. Just yesterday, with the governor's the declaration of emergency, the State Department of Health, Bureau of EMS, put out some guidelines that are saying that they want us to implement, once arrival of the ambulance, we would tell the folks, no, you don't qualify for transport. So it would be a no transport after arrival, which we've never done before. Part of the criteria is that you have to have a temperature of less than 100.4 and a pulse ox of greater than 94%. Problem with our units, we can't follow that protocol because we do not have thermometers on board, and pulse ox at the moment, although it's allowed by BLS, cost issues and numbers issues, we only have them on our paramedic units. So we wouldn't be able to comply with that actual protocol. The other thing is it would require that anyone who insists still on going, online medical control would be contacted, and then the physician would tell them, no, in this state of emergency, we're not taking you. Right now, just with the call volumes increasing, we've heard that some of our crews from the field are waiting over an hour for the lower priority refusal type calls. So what we've implemented also is we had a 10-minute rule in a patient destination that we have about 60 911 receiving emergency departments, we would allow a stable patient to go 10 minutes beyond the closest to a hospital of their choice. We have actually eliminated that. So now it's closest appropriate. So obviously trauma patients to trauma centers, burn to burn, but general emergency department complaints would go to the closest, and that choice would no longer be available.
Yeah.
And if they decided that they didn't want to go to a further hospital, then we would actually not honor the transport. We would make sure they have decisional capacity, and we document that the reason they don't want to go to the hospital now is because of not being the hospital choice. And because our telemetry is being overwhelmed with these RMA calls, we've also made it so that even in high-risk candidate patients, as long as they have decisional capacity and understand the risks, so somebody having an MI, they can actually be RMA'd without having to contact telemetry. We've also eliminated some of the response
Glenn, I'm going to
of
want
our ambulances and 2 ambulances, an ALS and a paramedic, only to the cardiac arrest calls.
Okay, hey Glenn, I'm going to need to interrupt you because I got to get Sandy on for a while. But if you will stay in there,
Yep, absolutely.
We'll bring this up later when we get to the transport alternatives. I have some other topics to cover there. So not too much time left, Sandy. I'm sorry about that, but if you can pipe in and Dr. Annie Schneider. Dr. Schneider, if you don't know, has been like the chairman of everything that ever existed and president of every organization, including ACEP and SAEM, et cetera, but is actually one of the finest people on the planet. And she is like the what we would call an associate executive directors, and therefore the highest level physician at the headquarters for the American College of Emergency Physicians nowadays, and has actually been sort of put in charge of ACEP's as the ACEP's point person for this. So Sandy, can you tell us a little bit about what's up there and what we need to know, and we can have you follow up later with us next week as well, okay?
So first off, on behalf of ACEP and everyone, thank you guys for what you're doing, because you are the front line for our front line. And many of you are our members. And I will tell you that everyone at ACEP and everyone in the whole community really is really pushing for you. I want to just give a real brief update on what ACEP is doing. Many of you already know this. In terms of, we early on set up some communication channels. There is a COVID page. If you go to www.acep.org/COVID-19, you'll see there is a large set of documents. We keep trying to curate these. I'm promised on Wednesday they will be better curated again of all the types of documents we've had. These are all vetted documents and documents that our members have given us permission to put up. In addition, we have a communication hub where people are talking about all of this stuff, and there's a link there to join that communication hub. This is only open right now to members. However, we are offering 3-month free membership to ACEP, so all of you can get onto this hub. And there's been a lot of chatter, obviously, around EMS, and a lot of chatter around what's going on, and a lot of chatter around PPE. In addition to that, we've put out a number of statements, and in the next week, you'll see us beginning to put out a series of best practices. And in fact, one of the things I hope to do from here is get some people that would be interested in writing some documents on best practices in EMS. I know you probably have those already on your sites, but it would be helpful. We have issued one on older physicians. We've issued one on PPE. In the next week or so, you'll see we have one on teletriage, ultrasound cleaning, resuscitation in this day and age, treatment of patients who are appropriate treatment for patients who are sent home to die, and rapid testing and oxygen use. All of those are in the works, and we hope to have a pretty standard document in the next couple of weeks. This will be a living, or next couple of days, excuse me. This is a living document, so it will change. We've been working with a lot of the other societies, including I talk with Deb Bowery almost daily at the CDC, nephrology, and we will be issuing a statement in the next few days around dialysis patients. Critical care medicine is working with us. Tomorrow I talk to the cardiologist regarding STEMI patients, because we hear that they have been refusing to come in some places. And we also, as I mentioned, are working with palliative care. So that's our sort of patient care types of things. I really welcome you to just email me. It's sschneider@acep.org. If you have any suggestions for other things we can do in that realm. In the other areas, we are very heavily involved in the federal group, And if Paul would like us to, we can bring on one of our federal people next week at this meeting to talk about all of what they're doing. But they have done everything from talking to the AAMC about medical students using PPE to being involved in today's announcement by the president. The other issue that we've gotten involved with, and we're not sure exactly how we're doing this at the moment, is donations of PPE. There are a lot of people who just Google emergency, find us and tell us that they have everything from 3 masks to 3,000 masks, or a couple of people who are willing to sell us masks at $10 a piece. We have issued a statement regarding, we feel now is the time to start using universal PPE, at least a surgical mask on all patients. That was because one of our docs was told not to wear a mask because it scared patients. So we are now saying, although this is not in line with the CDC, that masks should be worn with all patients, at least a surgical mask. We prefer an N95. We are suggesting that people wear the mask all day. It's terribly uncomfortable, but wear the same mask all day. Best practice on that would be to put a surgical mask over an N95 mask. If that's not possible, and change the N95 every day. If that's not possible, get 2 N95 masks, bleach them, or in any way disinfect them. Put a surgical mask over. If you don't have an N95 mask, then a surgical mask. And if you don't have a surgical mask, the CDC has already suggested wearing a bandana. That's pretty much it. I welcome any of you to help me out in things where you see that we're missing, in things that we can help. I invite you all to join the COVID community hub, communication hub rather, and discuss the issues in that forum. If you just want to summarize it. Oh, one thing I forgot, that page with all of the stuff, we summarize that twice a day, and that is posted on that page. So if you just want to look at what happened in the last 12 hours, you can go and look at that page. It's right at the top. So any questions? I have, nope, I have a minute before I'm on my next webinar, so I gotta go.
So, yeah, the only thing I do want to say is that you and I have already started to talk about the issues of alternative standard of practices and crisis standards of practice, and also looking at how we're going to do scarce resources in triage. So you're on top of that one as well, right?
Right, and we have those pages going right now on the COVID community hub. It's called Engaged, but that conversation, and there's a lot of chatter around crisis standard of care right now.
Right, and then the second thing is that, alter things. So for example, we'll have Ken Sheppy later talking about how they're converting surgery centers to ICUs and things like that. There are other constructive kind of approaches that would be kind of nice for everybody to use and have their further portfolio. I better let you go. Thank you for being on board. There's going to be a lot of cool stuff. Hopefully Jim, Augustine, and Craig can keep in touch with you as well as being kind of point persons for us. Okay, so
thank you guys. Thank you for what you're doing. We really appreciate it very much.
Okay. All right, thank you. Okay, I'll see you. Okay, all right, so let's move on. What I'd like to do at this point in time, just because it would be actually interesting, is I wanted to see if Dr. Vincent is there, Professor Jean-Louis Vincent from Brussels. Are you on the line by any chance? He was supposed to try to get on board, so may not have been able to make it. He's like one of the busiest guys on the planet. But essentially, some of the things he told me this morning were some of the things I mentioned before. If he can pipe in any time, let me know, Jean-Louis, if you happen to be there and you're just not unmuted, okay, at that point in time. All right, so I wanted to, maybe as we're doing this, talk a little bit about a few things like what's happening in other cities, since we'll just go along the lines of what we just heard from Glenn. I hope everybody can, though, keep it very short, like maybe a 20 to 30 second blurb on what's might be happening in your realm. I think Meg Marino, are you or Emily on the line by any chance? And can you tell us, I think things are starting to hit in New Orleans, if I remember correctly, right?
Yes, so yes, I'm here. We've had, as of yesterday, 1,172 cases in Louisiana that has just really blossomed over the last 15 days. We've had 34 deaths. The majority of those are in the greater New Orleans area, and we've been doing everything that we can to try to really quickly ramp up our responses and really pivot to this unprecedented time. So we've been really grateful to hear what other cities are doing. Our current question right now is we're trying to figure out if we need to decrease the number of cardiac arrests that we work, or decrease the length of time that we work them, especially in patients that are found down on arrival.
Right. Yeah. And if they're like, whatever, elderly, asystolic, and, no one did CPR, which are, so you'd ramp those up, but that would kind of make sense. All right. And then we'll listen on. If you want to pipe in later, let us know. I know that you guys are getting hit. Crawford, are you on the line? You want to talk about Philadelphia, since that's up in the Northeast near New York? Is it as bad as New York, or you just haven't been hit yet? Crawford Beecham from, are you there from Philadelphia? Crawford was on the line, maybe just not unmuted.
Can you hear?
Yeah, I can hear you now.
I am here.
Go ahead.
Yeah, fortunately, we're not as bad as New York, and hopefully we'll keep it that way. As of yesterday, we had 175 cases in the city, and a lot of this number may reflect the fact that we're doing increased testing. We have a few sort of freestanding testing facilities now, some of which are drive-through facilities. And they're not just for the worried well, they're specifically for people with specific indications. We have the same supply issues as everyone else. We're under the similar stay-at-home orders. Fortunately, our EMS volume is actually down. And I've worked a few clinical shifts in the last week, and our ED volume has been down as well. So I think those are good for us. But that being said, there's no guarantee it's going to stay that way.
And then do you think, you have any just, I guess, or speculations of why you didn't get hit as hard as New York? I mean, there's some similarities there.
We're less of a sort of a universal city. There may be just less travel issues. Don't know. And like I said, there's no guarantee it's going to stay that way. We may just be a little bit behind the curve.
Okay. And let's move out. Is Chris Colwyn on the phone, or Clement Ye from San Francisco? Are you out there? And if not, I'll maybe move in. I think Joelle's there. You want to talk about San Diego?
Yeah, sorry, I had to unmute myself. We are just starting to see the spike of COVID positive. We are also short on COVID testing and trying to clarify at this point, even if you are in the group that is recommended to get COVID testing, who actually of that group is the highest level that needs to get it for epidemiologic reasons, that we can really trace it. Our fire department's moved to, you don't have to have a positive test to diagnose COVID for our personnel. We are having, if you are asymptomatic, you teleconference into our occupational health, speak to a physician who determines you have presumed COVID, and then we determine if you need to have a COVID test based on further information. So we're actually working pretty dynamically to figure out how to keep our forces going, and then what are the trigger steps for moving to the next step. Question for those who are out there and listening, and you can feel free to email me or text me or just respond to the little group. And I apologize, I'm parking as I'm talking. We're trying to predict the fire that's coming towards us. When are you seeing your volumes go up? So we're open and we're planning and we've got all of our operations going, and we're trying to see when are we going to get the spike in ALS calls, BLS calls, increased use of equipment. What is a good approximation of when we should expect the volume bounce? Sorry, talking and driving are not my forte.
Yeah. Well, it could be tomorrow, but anybody else can pipe in,
Because we're down in volumes just like everyone else is right now in the early stages.
All right, got it. Well, yeah, we'll have people communicate with you directly then, I think, if offline, so we can get through the rest of the agenda here. And so I think that's a good question, et cetera. But just know it could be tomorrow and it could be 2 weeks from now, and it may not happen as hard as in New York. We'll just have to see for you in San Diego. Chris Zuver, let me ask you this, if you're around. So you've not only got Orange County, Florida, and Orlando, but you have Disney World there, and therefore people coming in and out from around the world up until recently when it closed down. Has that had an impact on you? Is that your perception? What do you think? Can you hear me, Chris? Yeah.
Yeah, Paul, I hear you. Can you hear me?
Yeah, you're on.
So, Disney's a ghost town right now. Disney closed all the parks and all the hotels. As of Friday, we have no more visitors, really, from that standpoint here. So our Disney side has really dropped off the volume. I think the fire rescue at Disney, ran no more than a handful of calls in the entire department. And that covers all of the Reedy Creek district. In terms of Orlando itself, while we're start to see an increase in our numbers as testing is opening up, we across the EDs in general and EMS, our volumes are down as well. I think mimicking what everyone else is seeing.
Okay. Now, I'm just curious because since you have such international travel coming in there up until a little while ago, I'm just curious to know if it had an impact there on you. I'm going to ask the same question, Dave Slattery out in Los Angeles, out in Las Vegas, for obvious reasons, especially because you get an elderly group out there as well. So you don't mind piping in, Dave, and tell us what you're experiencing so far?
Yeah, good morning, everyone. We're still in the early phase of this. We've got in Southern Nevada 212 cases, 4 deaths so far. About almost 50% of our cases are younger people, 25 to 49 years of age. And so we certainly do have the next big jump is those above 50 and 60. But it's interesting, unlike some of the earlier data, that our younger population is being affected and getting symptomatic. Okay. So from an EMS perspective, we've been aggressive call screening, adjusting with the switch from travel to community spread. As of Friday, we are donning N95 masks, gloves, and goggles on every call.
Okay.
And obviously full MEG PPE for any critical patient, as everyone else is doing.
And are you having shelter-in-place mandates yet, or what's happened out there?
Yeah, so the governor proportionally, voluntarily initially, and then gave the directive to close unessential businesses. So the Strip looks like a ghost town also right now.
Yeah.
All the major hotels are not up and functioning right now.
Yeah.
And so, but there's still way too many people on the streets, And so we need to be more aggressive and learn from the other cities that have done aggressive social distancing.
All right.
Schools are closed and, being delivered by remote when possible. Our hospitals are, getting ready for the tsunami. We do not have enough PPE, obviously, in the hospital environment. And there's still a lot of barriers for our nurses and physicians. We have a dedicated, University Medical Center, dedicated COVID area, just probably like many other hospitals. We screen people before they come into the ED and shift them all to one area. And then we have one provider working in those beds right now. We'll be expanding that area as we need to.
Okay, let me move on then. And Chris Colwell, you're on the line from San Francisco. You guys did an early clampdown recently of shelter-in-place kind of mode. What happened with that? Are you doing okay so far, or not, or what are you experiencing?
Yeah, so we've been in shelter-in-place now for 6 days. Our volumes are down, but not hugely down. So we're down probably about 18 to 20%, both from a EMS standpoint and from the ED standpoint. We're seeing about 30% URIs, kind of related complaints. And we have, as of this morning, 140 positives with no deaths, and about 20 of those are in the hospital. So our floors are very busy. The EDs are maintaining right now. ICUs are not overwhelmed at this moment. We've got plenty of ventilators for the time being.
Okay. All right. So that sounds good. So I got a little bit of a biopsy. There's a lot more people in between, but I'll try to, if we have time, we'll come back to that. I just wanted to get some discussion going. For something completely different, one of the people on the phone who's been monitoring this, and we've been helping him, has been one of our good friends is Scott Nichols. Scott, you guys have met at Eagles meetings before. And Scott, I'm going to have you pipe in, so get ready. So Scott has been responsible for he's like the head of security for numerous groups. Right now he's working with Garth Brooks, with U2, with Madonna, Lady Gaga, etc. I could go on and on. And so in any event, I just was curious from his point of view is that this has probably impacted your industry, and what are the kind of plans that you're doing for when people come back? Is this going to change what you're going to do in the future in terms of audiences and groups, or more, if you can, give us a quick rundown in about, let's say, a couple minutes, if you don't mind. And Scott, are you there? What if we lost him? We may have lost him. We'll see. Okay. He may not be able to plug in. I don't know. Are we have him unmuted, or can we unmute him? Maybe I can unmute him here. So, Julianne, are you seeing that? It's a 734 number. Can you unmute him? Okay.
He appears to be unmuted.
Are you there?
Yeah, we got you. There, go ahead.
Okay, well, thanks everybody. Thanks for the time. Real quickly, our industry, obviously, everything, what we do is mass gathering events, has definitely impacted this, and I think everybody's on pause, most likely. We're hoping June that things tend to get wrapped up, but realistically, we're looking like September, where things kind of get a wrap on. So a lot of these mass gathering events are most likely going to be postponed until later into the third, fourth quarter. The steps that are going to be taken is still in discussion, and it's more of an insurance and underwriting product that's probably going to come into place, because there's no kind of insurance that backs these cancellation things up. So moving forward with this, I think everybody's in a holding pattern and postponing and pushing things later into the year until the medical community and our government get things under wrap and try to slow this thing down and fight that curve. So that's pretty much where we stand.
And is there talk, though, you're saying it's in discussion, is there talk about how you would change procedures about how people come into a mass gathering, or any of that being upgraded yet, or you don't know?
Well, there's multiple task force being developed within the stakeholders to look at strategies on try to combat. I mean, obviously the safety and security elements are always in place with various layers of security of public coming in. I think public awareness is going to be more at the forefront for communicating to the public of to-dos and don'ts prior to coming in. I think purchasing tickets, there's probably going to be more legalities in the ticketing wording when they start buying these type of tickets, of the pros and cons and what to do when they're at the event for the legalities of that aspect. The safety and security for viruses, it's kind of like an unknown God clause, because these things can pop up anywhere at any given time. I know during the SARS event, we had to cancel the show, the Rolling Stones, going through Asia when that happened, simply because there isn't anything to back that. So things tend to get shut down pretty quickly when it's a viral type infection going on in general.
Well, it's just interesting because it's sort of the antithesis. Your situation is the antithesis of social distancing. So, as you know, especially in that front gate at the Mojo. Well, anyways, that was it. I just wanted to sort of let everybody know that that's part of our deal too, because we have to do mass gatherings and to kind of be aware of what's happening on that end of the spectrum as I move into the next area that I got to get to. So thank you very much, Scott. Thanks for what you do. And thanks for being part of us and working with us. And I think most of you have gotten to meet him at one time or another as we've moved through the with various tours. Okay.
Absolutely.
So good. Thank you again. All right. So now what I want to do is talk a little bit about universal precautions. I wrote up a little thing here, as it calls universal cautions about universal precautions. And so Brent Meyer, who's has been the past president of the National Association of EMS Physicians and now is the chief medical officer with the ESO, has got some data that he's collected on utilization. If you could do that real briefly, and then we want to have a discussion about the issues of is this a distribution versus availability issue, and then alternative approaches that we might use. Brett, are you there? And can you take it away?
Sure. Thanks, Paul. For those on the video, if it's okay, I'll share a screen real quickly, just a minute or two and come right back up. Is that okay with you, Paul?
Yeah, please.
Okay.
Yeah, if Julian can handle that for you, it's good.
And then I will, I'll talk about this for people that are just on the phone. So basically, we were on the phone yesterday with NHTSA, with all the other vendors, and we're working very hard to get to an agnostic dashboard that is not any industry specific, but there's some legal things that are beyond the scope of this conversation. So this is not meant to be ESO centric. It's just we can't get to the global one just yet. But the point that I wanted to bring up is that we're looking at the trend in N95 utilization, eye protection, surgical mask, and gown, and PAPR. And what we're seeing is that on an average volume, and everybody else is seeing the same, we normally see about 27,000 calls a day into this database. They're down to about 22 to 23,000 a day now, which is what everybody else is seeing. But if you look at the number of N95s utilized, it's almost 9,300 on a call volume of 23,000. So if you just do quick math out to the national average, that would be about 9.5 to 11 million N95s annually just for the EMS response. So I wanted to bring that up just to demonstrate that the N95 utilization is going to be an issue. Obviously, we can reuse some, but that's an issue. And just real quickly, just to give an idea, of all patients with a COVID EMS response, 98% required no airway intervention whatsoever. So preparing for airway is important, but it's a very small slice. And only 9% of patients with a COVID response had any medication administered by EMS at all. And of those medications, they were airway sedation, very few, analgesia, 1 dose of antibiotic that was in a facility, a lot of antiemetic, which is interesting, bronchodilators you would anticipate, and then there were some critical interfacilities that had various cardiac compressor meds. But we have this page up publicly to help folks think about how to prepare and what type of meds people might utilize. And this one will be on there tomorrow, which looks at the influenza year over year, influenza-like illness, and then you can see what's happened just in the United States in the past 2 weeks. We've had a spike of almost, doubling of influenza-like illness. So we're trying to put this out for folks to be able to see. And Paul, I don't want to take any more time.
No, it's been great. And then I'll keep you on the line to talk about some of this. We put down on this agenda here, and maybe it could be posted by Julian, but there's a web page that is the HTTPS, et cetera, that is eso.com/COVID-19, et cetera, right?
Yeah,
so
and I'll just send that, if you don't mind, I'll just send that link in and then on the text, and then people can.
Yeah, good. Thank you so much. Then that's great. Thanks for keeping on top of it. Craig, can you pipe in about this issue? Is it really an availability issue, or is it a distribution issue, or what are some of the other factors that are going on in play here?
Yeah, I don't want to be the opposite of everybody's concerns regarding PPE because everybody is scrambling to get the hands on PPE and get it in the ambulances and for our personnel. But there is not a manufacturing issue associated with PPE currently. If we keep the discussion to N95 mask, in China alone, they're producing 5 million masks a day currently as we sit here and speak. The problem is in the distribution cycle, in the logistics change for your healthcare systems and your procurement systems. Certainly the price has gone up. You heard Governor Cuomo talk about yesterday from 85 cents that they were paying, and some of the price gouging going on up to $8 and things like that. But the problem is these are in non-traditional distribution chains. So the McKessons, the Cardinals, and those folks aren't able to access them immediately. They're starting to look at supplies a few months out, and we'll be able to get that, and we'll get back to a norm. But the production is ongoing. The difficulty is getting it from these non-traditional distributors and suppliers into our logistics chain. So that's slowly working. And these aren't just orders of a couple hundred. These are orders of thousands and millions. Sitting today in Los Angeles, there's a warehouse full of 24 million N95 masks that have been started to be processed for movement for government or state and federal government entities. There's warehouses in Hawaii that are full of these supplies that the distributors are trying to get out to. Now, I'll give you an example. One of those examples is the city of Houston. So I'll call out Chris Souders here today. An order is being placed, and it's taken over 72 hours for an order for 2 million N95 masks to be placed. And those are for 3M, original manufactured masks, not knockoffs and things like that. They're requiring a cash on delivery post with a net 60 to 90 days so that the distributor is not going to be paid for another 60 or 90 days from the after delivery. And so therefore those distributors are having to go out and secure financing in order to get those type of large orders moved out. So if you're willing to, put some cash down, be able to move that, there are distributors out there who can make that happen currently. And so again, I just wanted to emphasize the production is there. This is crazy that we're having people make masks out of HVAC filters and having to reuse and recycle supplies right now. But if you have your logistics folks go to some of the non-traditional places, we can get those. Offline, I'm happy to share contact information for some of the distributors. You will need to do your own vetting and negotiation, but I know folks who are selling masks in thousands and a million order at a time for $3.50 to $4, and so there's not price gouging. These are available. It's finding the right logistics change management within your organizations to make this happen and things. The other thing was,
hey Craig, I'm sorry, it's Data. Can I ask you any issues with counterfeit N95s? We actually were offered some masks that we thought were good. They gave us a European certificate, but apparently it's not the same as our NIOSH certification level, so we couldn't purchase them.
Right. Yeah, I'm sure that there are, and that's why I was just saying that you need to do your vetting of the products and the distributors. Whenever you have these additional logistics chains open up, then you have to be very aware of that. But I think part of the risk mitigation goes along with the NIOSH certification versus using nothing, using an HVAC filter from Home Depot that's been covered in cotton cloth. And those sorts of things that are out there. So I really think this issue will be resolved in a few weeks to 1 to 2 months. But the problem is the here and now and trying to get the mask in everybody's hands and things.
So that's a segue into what alternatives and what you could do in the interim. First, before I go to those kinds of discussions, I want to go to Savinsky, is our Eagle in Hamburg, Germany. And Godo, I don't know if you get online with us or not, and just tell us, are you having the similar problems there with PPE?
30 seconds ago, so I didn't follow your discussion the last half an hour.
Well, part of this was about largely what this is about is having the PPE, the availability of PPE and masks. Are you having shortages there?
Oh yes, we have great big shortages of masks and suits. That's a big issue for us. Right now, we think we can stand up to 5 days, and then we don't have any more PPE.
Okay. So the discussion, if you just missed it, was that it may be more of a distribution issue and not availability. There are probably a lot of sources out there, and so we're going to talk a little bit about that. And in the meantime, what are we going to do while we're waiting for those distributions to come in? And then I know that one of the comments I saw before from Lakshmi from Atlanta was that they're having to use the N95s and assigning for one for each paramedic, and then putting a surgical mask over, as we heard earlier today. But then Mike Sayer, you said some of the N95 usage. I was trying to understand what you were telling me here about in terms of misses the diagnosis in a substantial number of COVID patients. Can you pipe in and tell us what you're trying to say there? I'll just try to get Mike Sayer on the line real quick. Mike,
right now
Okay.
In Hamburg, we are trying to store the old mask for reuse after 7 or to 10 days.
Okay. And are you doing any cleaning procedures?
Right now, we don't plan any cleaning procedures, but maybe there is a new procedure available. We are just testing it with plasma sterilization.
Okay. What kind of sterilization? Say it again.
With a plasma sterilization.
Yeah. Okay. Got it. All right. And then, so I'm going to move over to Jim. Do you want to pipe in here, Jim Augustine, at this point in time? If you're
I'm
there.
very good. I'm on. Julian, you got me?
So what are we talking about in terms of possibilities while we're waiting for the supply chain to come in? What are we doing in the interim? Because you work closely with the International Firefighters Associations, right? So
International Association of Fire Chiefs. We just came off that call. And in addition to what Craig said, China is making, but at the current time, the FedEx, UPS, and other commercials are not allowed to distribute any of product coming out of either China or India. So there's an additional logistics issue. What we've been discussing at the Eagles is the airway problems, and those are replicated in the hospitals with a movement towards only fully protected people doing airway procedures on COVID or potential COVID patients. I thank all those who contributed what's going on in their region. The second and very important one was where are we moving into the non-transport arena? And it's obvious that the cities that have warm handoff capabilities are able to move to a no response or no transport system, whereas cities that don't have any kind of a warm handoff capability to public health or the hospitals are not going to be able to do the no response, no transport. We have 34 replies to that already. We have none from out of the country, Paul, and I'd love to have some of our international participants who are on the call send in their information about what they're doing with no response, no transport. But currently, the ones that did respond are moving within the next 2 weeks. Cincinnati, Ohio has 2 ventilator patients with COVID in the hospitals currently. In Youngstown, there are 44. So Joelle, as you were talking about how quickly this moves, we're about a week behind, looking at upticks in volumes of patients coming to the ED, moving to where the ICUs begin to get strained, and it's about a week difference in that timeline. So Paul, thank you for that opportunity. I'd be glad to answer any questions offline.
Well, just getting into the issue about we just don't have any policies up there, but there are people who are developing, I think, some policies. Sorry, something just popped up in front of me. I don't know what this is about, so sorry about that. There is I got to get rid of it. Okay. There is issues about the non-transport. So in other words, I think there were some people that have had some or were developing some protocols. Has anybody completed one yet, and that we could get shared out there? You could get on the regular Eagles website about that.
Ken Shepke has a wonderful set of documents from the state of Florida. Tom Collins has a very nice set from Cleveland. Those, thanks to all of you who sent yours in. Those are the best 2 and the most comprehensive that I've seen so far.
Okay. Then there was this issue about the big, I called it paper or plastic here, bagging. And we were looking at the Eagles survey on bagging. What did that end up turning out to be about for patients we had assist ventilation with, correct?
Right. It's very clear that everybody's moved to the supraglottic airways. And so those patients, bagging, and of course ventilators are short, and I anticipate the ventilators, any that we have that are transport ventilators, are going to be sucked into the hospitals. So bagging and making appropriate use of filters where available, and like Peter Antevi shared one filter set that also had incorporated end-tidal CO2. I think we're going to see some great new products come available as a result of this also.
Well, what I want to do is if Mike Sayer can get on the line again. It's interesting that as we all were moving to supraglottics, I think Mike has had a different experience right now. Mike, can you pipe in here now?
Yeah, I can. Sorry about that. I was just taking a call on this issue. So we tried this strategy of using iGel instead of endotracheal intubation, and that's proven not to be a good plan. So what we have observed in patients with disease is that there's a lot of secretions, there's a lot of aerosolization of these secretions that occur with the iGel, and we may be inadvertently actually causing more exposure to our teams, both out of hospital and in hospital by using this strategy.
Right.
So we are going to start walking that back this morning.
And you guys are basically have traditionally, because you have a tiered response system, so a small cadre of medics, and so you have highly skilled people that do endotracheal intubation, right? And so on, correct?
Yeah, correct. So this would be for an RSI cohort. That's what we're kind of looking at. But even for the cardiac arrest cohort, it would be the same. I mean, the cardiac arrest cases, I don't know that we've done CPR on a COVID positive patient. I don't think we have.
Okay.
In the out of hospital setting yet. I'm sure it'll happen, but I don't think we've done that.
Hey, Mike, before you get off, I just wanted to just quickly go back. There was a thing that you raised up earlier about some of the reuse of N95 mask misses the diagnosis of substantial minority. What was that about? I'm trying to understand what you were saying in that comment.
So in our COVID positive cohort, the EMS did not diagnose COVID disease.
Okay.
Patients of substantial minority are presenting roughly a third with other diagnoses where the disease is not considered by EMS.
Yeah.
And some of these are falls, some of these are altered mental status, some of these are chest pain. So strategies that are, how shall I say this, relying on
shortness of breath and cough and dyspnea, right?
Yeah, to decide whether or not to wear N95s
Yeah.
are likely to not work very well for some of the workers.
So it should be more used more universally. Now, going back to the issue about the SGAs, one question came up was if anybody was experiencing a shortage of SGAs. And I think, John Jew, if you can plug in first and say, in Portland, you've moved to VLs, right, as the primary airway. Tell us about that, if you wouldn't mind.
Yeah, we looked at Mike's recommendation, and looking at the Chinese data as well as the Korean data, they found that basically suctioning was very important in prone positioning with high levels of PEEP. So we also decided that there's only sense for one of us healthcare workers to be exposed, and that would basically avoid the emergency physicians and the ICU physicians from intubating if at all possible. So we've made the hard decision to use VL, video laryngoscopy only, and hopefully that will be our experience as well. But we agree with Mike.
Okay, so it's interesting then, that issue about the shortage of SGAs coming up. I wonder if that'll end up being a moot question for us all, but we're all learning at this point in time. And
so Paul, can I just jump in one more point here? So when we do this, we're making sure our crews are, protected. So they are wearing N95s when doing any airway management.
Yeah.
So any manipulation of the airway equals an N95.
Yep.
Yeah.
So, by the way, I just want to make sure everybody knew that was Mike Sayer, who's been having to handle the Seattle situation. Yeah. And then John Jew, our infectious disease colleague and medical director for Portland and the surrounding county, is on the line now. John, go ahead.
Yeah, we're using full face APRs and PAPRs on our procedures if we're able to get to them. Our minimum is P100s with goggles and full face mask as well. So we are pretty well protected. We've been moved about a week and a half. We moved to everybody with all PPE during the entire call.
Okay, got it. All right, and then next question I have for you. One thing I should bring up, since John's on the line, is we were going to open this up with a large discussion about actually the clinical course of the disease, because what Michael's referring in some respects, but also more broadly, is that we think that the disease is very chimeric in some respects. The people who end up going to the hospital and actually get help probably are those who are having shortness of breath, and now higher fevers, respiratory distress, and so on. And that has given us the sort of the sense that that's what the disease presentation is. I think most of us are coming to believe that there are some prodromal things that take place, for lack of a better word, I guess. I don't know if you want to call it just the early part of the symptoms, or And then they just erupt later on. And in some cases, people are having no symptoms, or they have these sort of myalgias and maybe real low-grade fevers. This or a little bit. We're writing up a whole paper on this, but it turns out that their exposure might have taken place, say, on a Wednesday. They don't get sick until Sunday or Monday, and then this sort of creeps along for a few days. The sick is not real sick. They're just kind of flu-like, as they say in the old days, but not so severe. And then all of a sudden, John is usually saying on the average, not always, maybe on day 8, day 9, they may start having the severe cough and respiratory symptoms and may crash. I was talking to Randy, and that's what the new, therefore that's the presenting, chief complaint, and that's what we may be hearing about. But so there may be a lot of people out there that are COVID positive we didn't know about, or we don't understand how the disease process. We're trying to put it together better. And of course, in individuals, it's going to change. So I was talking last night to Randy Katz. I don't know if Randy, are you on the line by any chance? I don't know if you're there. But I was talking to him, and he said he had a person who came in basically with just diarrhea only, myalgias and diarrhea. That was it. And it wasn't severe diarrhea. It just was some diarrhea and some myalgias, and then piped in, and he it was COVID positive. So, and that's what we're hearing a little bit more about GI stuff. Peter, were you going to pipe in here? Did you have a comment? Peter Antevi from Broward County, because that's where Randy works out of, right?
I'm going to pipe in Randy, but there was a lot of feedback here.
Oh, I see. Okay, got it. All right. Well, we can get him to talk later, but I wanted to at least recognize that that's what I'm trying to ascertain from you clinicians, what you're seeing, and to keep your eyes open for what I just talked about the prodromal event. And then maybe sometimes people are actually feeling kind of lousy, and they have these fevers that kind of come and go. They're very low grade, and then all of a sudden they may feel a little bit better, and then they get into a respiratory thing that either clears up in a couple of days, or they may really start going down the tubes over the next 3 or 4 days after that, if not immediately. And so we're going to do a whole presentation about that next week, and talk about positivity and how positive tests may not necessarily reflect infectivity. And sometimes you may still be infectious and you have a negative test, and we're going to talk about the timelines on those. We're learning a little bit more as we go along. John, do you want to give a quick comment and give us a sort of a break tease about what we're going to do next week? And we may also put a paper out on that as well, right, John?
Yeah, we're looking at that. The first one is first comment is that we don't currently have. I think the Chinese have serology, and that's their baseline. But if you compare serology with the positive swab, serology obviously is our gold standard, and positive swab, either being oral or nasopharynx, is about 80%, 70 to 80% sensitive, and obviously 99.9% specific, depending upon the time of sampling and how you sample as well. So one swab does not tell you anything. 2 swabs probably tells you something here as well. Don't depend upon the swab to rule out anything at this time.
And then, so if you don't mind, for next week, I would like to maybe focus a little bit more on that, about the clinical course, when things are positive and negative, and then also talk a little bit about perhaps, when we would basically send people back to work, okay, that may have gotten sick in our workforce and all that. Mike, you have, Mike in Seattle, you've had the most experience with this. We can probably drill down on this more next week. Can you give us a quick eye opener about that, about when you think people are ready to go back to work?
Yeah, we've built a fairly complicated algorithm for the confirmed exposure cohort, and then the cohort with no known exposure, and essentially continue to be able to just put people in quarantine for 14 days after an exposure. And at the end of that time, if they never got sick, they can go back to work. One of the things the city's working on now is, since the hotels are empty, we finally have hotels reaching out saying, oh, we might be willing to put some of your guys up in our hotel if they need quarantine. So that wasn't possible 2 weeks ago, but now it is. And so I think we're going to take advantage of that opportunity for some of these folks.
Are they charging?
I'm sure they will, and the city will happily pay it.
Maybe they'll get a government rate.
Yeah, well, they want the business, right? It's a win-win.
In my case, I'll get a senior rate, right?
And I'm really pretty impressed with what South Korea did around this.
Yeah.
So if you tested positive, you could not go home, period. You went to a hotel, you went to a dorm, you went somewhere else. And that's how they interrupted the transmission.
Okay. Hey, before I move on to, because we're sort of gonna not drill down so much on things at this point in time, but there are things that we will talk about next time, which is the upcoming tests that are we done. One is actually already out, something called Expert, that will probably be more widely distributed by March 30th. And that's, again, another swab test. If anybody's have a swab test, I don't know if Jim Roach is there or not. We talked about this. I actually got mine. Unfortunately, I was negative, but it was like a brain biopsy. It was like one of the most painful things. You know, if you've ever seen your patients get a flu test, you'll know, or if you had one yourself. But anyways, that's still doing this. But there are other things coming down the line. There is one point of care finger test that will look at the serology actually and give you a turnaround in 10 minutes, but it has not yet been FDA approved. John, is that coming around, and what do you think of the product yourself so far?
I really don't have any comment. And as you heard from yesterday, there's been a lot of groups that have been touted to have a solution. We have to be very careful in
Right.
adopting a solution here as well. So I don't have any comment on that other tests.
Yeah. And the first
that's
trials on remdesivir have just started, right?
Sorry, that's correct. There is a group of investigators, including around the country. I can't remember the name of it. ICU investigators that are basically trying multiple agents, including remdesivir.
Right. Okay. So, yeah, go ahead. Yes.
Yeah, I just wanted to mention that Dr. Adams and Dr. Cliff from City of Miami are being very innovative, and they actually have some of those samples of those point of care tests coming into them, and they're going to be trialing those. And they're also using another test that they're actually sending out their medics to the patient, doing the swab, and then getting the results turned around within 24 hours. They're on the call, just that they're muted on the call.
Okay. Well, but the good thing is that hopefully when we've talked about this, we should study it well and make sure that how they're correlating with serology and so on, and or with even with the nose test if you have to. It would be just kind of interesting, right? So what I was going to say was, Joe Holly, are you online? Can we unleash Joe for a second out of Memphis?
Hey, good morning.
Yeah. So do you have any comment? You were talking about, should we do this more often? I want to see what the people, why don't you give us your rationale for doing that? And then let's see what the group thinks.
So my thought is that we are in clearly a logarithmic part of the curve here where things are changing very frequently. And I think there is great value in maybe every third or fourth day in order to stay on top of a rapidly changing situation.
Yeah, because yeah, and I feel bad because I can't get everybody on, and I want to do that. I still like to open it up, and you know, as you know, our Eagle Creek meetings can go on for a whole day, and so that may be an issue, you know, for us. And hopefully, people are able to read the comments, such as Scott Gilmore is putting in about how St. Louis County, a quarantine hotel, was set up for first responders a week ago. So that, I think that's great if you guys can at least pipe in some of the things that you can give on the call without necessarily getting on the call itself. So that's very useful. But I don't know what your druthers are. If we did do it, when would we do it? What would be most optimal? It would be like a Tuesday, Friday or something like that. Is the same time okay? Should we do it later and get our people from Australia on board? So things like that. Let's have a chat about that offline, and we'll see if we do it. Maybe we'll offer. What's the general sentiment, or people sound like that might be a good idea, at least for the immediate future? Okay, I got a couple thumbs up so far that I'm seeing on the pictures, the video. So hopefully that's good. Okay, we'll explore that. Okay, and it's really up to you, I think, Craig and you know, Craig and Julian, if you can help us do that, et cetera, if it's doable. So there's a lot of people on the call here today, and I just want to see if I can get anybody else to pipe in for right now, if there's any other topics to bring in. Ken, are you on the line? Ken Shepke, for example?
Yeah, so Paul, Ken had to leave because he's in the EOC doing other things, but he wanted me to update the group on the Surgery Center.
Yeah, what was that? So again, this is Peter Antevi, who's our pediatric guru, and also the chairman of the Greater Broward Emergency Medical Services Medical Directors Association in Broward County, and he works with Ken Shepke, who's not only his counterpart in Palm Beach County, but also the medical director for the state of Florida. Go ahead.
Yeah, so Ken's working really hard to get the Surgery Center assets kind of into the system. These are not the surgery centers that are affiliated with the hospitals. They're basically the privately owned ones. They all have anesthetists. They have folks who there can work as respiratory therapists. So there's about 2,000 beds that can come into the system that have ventilator capability based on that. That's the main message you wanted me to get across.
Okay, got it. Thank you then. So just another thing that's out there, et cetera. Anybody else want to pipe in at all? By the way, is Jean-Louis ever pipe in? Did Jean-Louis ever come in from Europe by any chance? And if not, but please get on. I don't know if his number is showing up. That's the only problem, that he may be muted. That's the thing. Yes.
I have some more insight on the China supply chain.
Yeah, please go ahead.
Yeah, so and I only know this because I've been dealing with a Chinese manufacturer for almost a decade with my other company. And essentially what we heard is that FEMA just made a big, again, this is all hearsay, third-party stuff. FEMA just made a big deal with the largest manufacturer of Chinese consumables in China. And so all the other distributors who are making things are going to be increasing their prices significantly. That's number one. The number of flights coming out of China into the main hubs like LAX, Miami, Chicago are going down. And so I think cost is an issue, but the supply chain, just like they had mentioned earlier, is not going to be complicated by the fact that the U.S. government is now going to be trying to get many of these consumables into their hands first. So it's not going to get easier, it's going to get harder. And so I think we really need to think about kind of how to get our folks the supplies, and that's kind of why I'm trying to do everything I can to just do it myself if possible, but that's not really a reality. We can't get masks, we can't get gowns.
So, all right, if you would, maybe you can make contact with Sandy Schneider directly and sort of see, because if she's talking to the feds about that, then that may be a one thing to make sure they're alert to that thing. That would be very helpful, right?
Well,
Yeah, Paul, they're already alerted to that.
Okay, good.
They recognize and are working those issues very hard right now.
Okay, fantastic then. Just as a quick note, I was going to go back to Godo real quick because we never finished him off, but because I did want to get a little biopsy of Europe, and he texted me back and said that he had to go off for a nursing home fire. So, that kind of thing. So it's just other things. So things are still the same today as ever, that kind of thing. Let's see, what else? Oh yeah, I'm just going to check this one thing.
Ken's typing in a question for me, for everybody, specifically either Glenn in New York or anyone from Italy. He wants to know if the hospitals are running out of emergency or capacity, or is it just ICU beds that's the main issue? And do they still have the bandwidth to handle emergency surgery? So if we can get that answer from somebody, that'd be great.
Okay. Glenn, are you still on?
Yes, I am. Hey, Peter. So we are running out of ICU beds to a point where some networks are trying to get their ICU patients transferred to their other networks in the Long Island area, which is either a county or two away, or to the Westchester County area north of New York City's 5 boroughs. Elective surgeries, as you know, have been canceled with the declaration of emergency. Emergency surgeries are still ongoing as the cases present. Our trauma centers, our stroke centers and things are open. Our STEMIs are all open, so the subspecialty categories are still open. But right now, the ICUs are having a difficult time, not only with these patients intubated from COVID, but also those that are having other conditions that need to be in the ICU bed. So there are a lot of issues that the hospitals are trying to deal with. Now, the governor is opening up a 2,000-bed facility at Jacob Javits, which is a convention center in Manhattan, but it's not going to be with ICU beds. It's going to be more for the lower acuity. It sounds good, but with the state declaration of emergency, EMS is allowed to go to other than 911 receiving emergency departments, but it doesn't make sense for us to try to get all the way to Manhattan. We have 5 boroughs. You could be on a further borough. It's not going to help us. Our operations would just be disastrous for them. So we're trying to recommend that, instead of a 2,000-bed hospital there, which is great, maybe add another 1,000-bed hospital in some of the other boroughs. That way we can realistically take lower acuity patients to those facilities instead of having to track, across 2 boroughs.
Okay. So the next question I have out there is, oh, well, first of all, I want to see if there's other people who haven't had the opportunity to pipe in, if they have a burning question or issue that they want to bring up that we should start addressing. Anybody else out there that wants to raise their hand? Is there a way, how do you raise the hand into this thing? Does everybody know how to do that, where it goes mute me or raise my hand? Is that right over there? I don't see that. RJ, can you tell us a little bit of what's happening? You guys are way advanced in some respects in terms of crisis management, crisis standards of care. If you're there, RJ Franscone from St. Paul. Minneapolis has taken a good lead role in that arena. Can you tell us a little bit what's happening in your neck of the woods? If I could get them.
We are flat or down, just like everybody else. We had our lowest volume in the ED at Regions 2 days ago that were lower than we've had in 10 years. And all of my services volumes are down right now. So it's the calm before the storm. Okay. And then do you have some operative plans for how you would handle crisis standards of care already, right? That made for both EMS and for the ICUs, correct? That's correct. And the ICU folks have active meetings right now regarding allocation of ventilators should that become necessary.
Right. And then there's some policies that the Minneapolis Department of Health has put out, and they've updated recently, just like we had here in North Texas some years ago. So I just want everybody to be aware of that. And again, I think ASAP's going to try to be part of that, and I've made sure they were alerted to how well you guys are doing there. RJ, have you developed any policies or contingencies for non-transport, by the way, in your area?
Yes, I sent in our policies earlier. It's a metro-wide regional protocol for catastrophic emergencies. The bottom line on it is we have not yet developed a policy. We're meeting on it right now on how to not respond by dispatch. We're looking at having a physician in the dispatch center.
Yeah. Okay. Wow. That's going to be interesting then. And then to some extent, have you guys had some experience with doing that already, just on a day-to-day basis in Houston, right? Chris, are you there on the phone? Chris Souders, who works with David's work there. Chris, are you there? Chris Souders from Houston.
Dr. Souders, it doesn't look like you're connected to audio on your Zoom.
Ah, okay. Well, okay. So, all right. Well, then we'll let that go at this point in time.
Paul, it's manifold, and I've got a pretty basic question for folks out there, and that is, what's the case definition for COVID-19 that is a clinical base? Everything that I've seen has been based on either testing and/or travel history, which we know is useless at this point in time. So, if anybody's seen a clinical case definition, I think that would be helpful for us, and particularly as we start to look at documentation and doing some of our research and things like that. So if anybody's seen something, post it or let us know. I think that would be helpful. Or maybe I'm just in the dark. So.
Yeah, I think it may be they're all in the dark. And again, the issues that I raised before with John Jew about the chimeric approach to these things and the time differences, it's a dynamic process in different individuals, really have muddied the waters on that. Clinical, but we're going to try to put a kind of a monograph together, which is like our best guess about what that is at this point in time, or at least the clinical course, so everybody can understand it a little bit better. And again, we're kind of trying to take our best stab at it this time, like what's outside of the articles that might be published out of China. We want to know, what are we seeing here in the United States, et cetera. So we'll try to put something together for you in the next week or so.
Dr. Pepe, can you hear me now?
Yes. Yeah. Okay, Chris?
Okay. Sorry, I recalled in. Houston, We're actually doing remarkably well. Only 150 cases in our entire region, which is 3 to 4 million people. In the fire department, only 1 positive firefighter, 3 positive police officers. We do have about 33 on quarantine because of possible exposures. But we are good with all supply except for gowns, which we are having a problem with gowns. And we're attributing our good luck so far either to the heat or to the long distances we all have to travel to go anywhere, and no communal, no subways or anything. We're just too spread out to spread it easily, I guess.
Yeah. Okay, good. All right. So I think we've been on this for an hour and a half, and I probably should start letting everybody go. And then it sounds like this has been well received. I'm just getting these little texts saying that this is a good dialogue. And it's still difficult because we're not in a room and I can't see everybody very well and I can't get them on right away. So it makes it a little bit awkward. But I'm hoping that there's a thing, if anybody doesn't know that, on your Zoom thing, if you have it, there's an area where you go to participants down at the bottom. You click on that, and that will come up, and you'll see at the bottom of all those, there's a thing where you raise your hand. So that'll help me know if you want to pipe in. I just want to make sure I increase involvement and not have to just call people sort of randomly. So that would be really helpful. But I think at this point we ought to take it or make it a wrap, and then we'll anticipate, maybe we'll think about doing something as early as Friday and let you know. If not, we'll be back same time, same station next Tuesday if no one objects to that. All right. Craig, anything else? Yeah, as you being our host, would you?
Absolutely. I'm just waiting. I'm watching Chief Clarkson on the video feed for us to give us a thumbs up that we can use Julian again for Friday or whenever we need to.
Yeah.
And so we got that. But again, we'll process the video. We'll put it up on the website on useagles.org. For people to access. Feel free to refer other people to share it. We've got a few additional documents that are posted that are one that came across our desks in our region. It's from Christine Baker, who is a scientist and advocate for IAFC, and she's added a fair number of monographs on N95 reuse, protection, PPE in general, worth the read and worth looking at the YouTube channel that she's put on. It's quality information, and other pieces that come about, we're happy to post as need be. And as always, we thank you for your participation and sharing this. I know I personally always find this a valuable source of information for us. And again, our ability to be colleagues and share information is just truly wonderful. We've also got to watch out for one another because times are going to increase in the stress levels that are out there for us and in our areas. And so we make sure that we always have that support group feel for us in this difficult job of being EMS medical director.
Yeah.
So
I was going to say is that, so just as a thing, hopefully John and I will have our act together and get that monograph together and then do a little review of it for you next time around. And we'll drill down on some more of these things that we were trying to capture today and learn a little bit more, especially about the cleaning purposes. Also, I've got some interesting articles just published today in Critical Care about how they're doing transports to hospital with positive patients or inter-hospital transports. And we'll try to post that, as well as an article that just came out in the New York Times a couple of days ago, which I thought were really interesting in terms of how the spikes are going or the blunting going in different cities. And they featured a little bit on Hong Kong and Singapore doing such a good job, which we've heard about before. So we'll try to get into it. And next time I'm going to try to bring Ed Rock on the phone. I don't know if he's on anymore today, but try to get him on board to talk a little bit about what's happening in his realm with AMR or GMR as it is now today. Okay, so want me call it officially adjournment, and thank you all for participating today. I'm Paul Pepe, and I approve this message, right?
There you go. Thanks, Paul. Appreciate your help.